Good morning, everyone, and thank you for joining our panel on outcomes and inconsistencies in health equity. My name is Michael Anderson Nathy, and I'm a principal consultant at HMA and have the honor of serving as the moderator. I want to just give a quick introduction to our topic and format for today, and then introduce our speakers and get into the session. I don't think it will come to anyone. I don't think it will come as a surprise to anyone in attendance today that the last year to year and a half has been unprecedented in our lifetimes. Between COVID-19, the political and social unrest, and an ever-increasing awareness of structural racism as a public health crisis, we have seen more and more focus and discussion on the topic of health equity, and in particular, the role of the healthcare system in advancing it. Today, our plan is to hear from each of our panelists on 3 specific questions related to our topic of health equity. I will introduce each question, and we will rotate through each speaker to give them a chance to weigh in. In particular, each presenter will provide some insights from their unique perspectives with the hopes of generating some discussion topics for our question and answer period that will follow. Feel free to post any questions you have in the chat panel, and other audience members can upvote questions, which will result in a prioritized list for our speakers to address. Additionally, if you would go ahead and put your name and organization in the chat now, that will help our speakers get a sense of who is in the audience. Now, let me introduce each speaker before we begin. Dr. Demetria Malloy, who also holds a master's in health sciences, is an internist who is a regional vice president and medical director for Anthem Blue Cross Blue Shield's National Accounts Team, an organization serving over 8 million members with 500 employer organizations across the country. She is focused on clinical program collaborations and innovation, physical health and mental health integration and population health management strategies, developing expertise in health equity and innovative solutions for the care of complex patients. Dr. Malloy has completed academic and clinical training at Stanford, Tufts, UCLA, Cedars-Sinai, and the VA healthcare systems, with additional leadership training in Robert Wood Johnson Foundation and California Healthcare Foundation programs. She has been with Anthem for 5 years and in clinical leadership positions across multiple lines of business, and has worked in leadership positions in clinical care, research, policy, and managed healthcare for the last 12 years. She has led teams in utilization and case management, provider enablement strategies, health equity and quality of care for vulnerable populations, and has an expertise in the design and implementation and scaling of innovative clinical programs that address complex patients. Dr. Malloy was named one of the Women of Influence 2020 by the Los Angeles Business Journal and led a team that was awarded the Health Equity Award 2020 by the California Department of Healthcare Services for a landmark doula services program that addressed maternal birth equity issues. Dr. Malloy has worked across various areas of the healthcare spectrum to build team synergies within clinical teams across regulatory, operations, and provider network access to increase efficiencies and improve patient care and organizational performance. Our next speaker, Eve Gelb, joined SCAN in 1997. As Senior Vice President, Member and Community Health, Eve is responsible for all care management and care coordination for all of SCAN's products, including special needs plans, Medicare Advantage, and SCAN's community service organization, Independence at Home. The SCAN model of care, caring for the whole person, has been meeting social needs as well as health needs since SCAN's inception as a social HMO. For the past 5 years, Eve has been leading SCAN's health equity work. Ms. Gelb has more than 25 years of healthcare experience, previously working at Texas Children's Hospital in Houston, where she built asthma education programs and primary care networks for low-income children. Ms. Gelb earned her Master's of Public Health degree from Tulane University and has a Bachelor of Arts degree from the University of California, Los Angeles. Finally, I would like to introduce Kristen Azar. As a Scientific Medical Director for the Sutter Health Institute for Advancing Health Equity, Kristen Azar leads an experienced, multidisciplinary group of clinicians, researchers, and administrators. The team is focused on using resources and data within Sutter's integrated network to incubate innovative solutions to eliminate health disparities. Over the past several years, Azar and team have generated data-driven insights, groundbreaking methodologies, and pragmatic solutions that can be directly applied into clinical settings to improve outcomes for Sutter's patients and those across the country. Azar joined Sutter Health's research enterprise in 2009. Since that time, she has led numerous published studies in the areas of health disparities, health equity, cardiometabolic disease, and mental health. Her research is aimed at identifying and addressing health disparities and examining the impact of social determinants of health on chronic disease risk and management. Azar has diverse clinical experience as a public health and preventative cardiology nurse in and outside the US, and has worked with racially, ethnically, and socioeconomically diverse populations. Azar holds graduate degrees from Johns Hopkins in nursing and public health, She completed undergraduate studies at the University of California, Berkeley, and obtained a Bachelor's of Science in Nursing from Johns Hopkins University. She is a member of the Sigma Theta Tau International Honor Society of Nursing, as well as the Delta Omega Honor Society for Public Health. Additionally, she was named a Fellow of the American Heart Association in 2018. Okay, so let's get started. So for our first question, I'm going to kick off with Dr. Malloy. Given the events of the last year, including COVID-19 and the clear disparities we see, the continued murder of Black and Brown individuals, and a rise in anti-Asian violence, we are seeing a heightened awareness of structural racism and its impacts on our communities, especially our communities of color. What is healthcare's role in addressing health inequities so that we equalize the experience for people of color and connect them with additional resources beyond the traditional healthcare services?
Yes, hello, thank you. I'm so pleased to be on with you all this morning with Eve and Kristen. I think it's a great timing for conversation, a great conversation to be had. There seems to be repeated trauma in this area to the nation and the communities, even as of late. So just to acknowledge that and to just show, how much active work needs to be done in these different areas. Thank you for your question. I think across the healthcare spectrum, every health entity and organization really can and should be doing something to impact particularly disparities or inequities that are sort of rampant throughout our system. And I think a general approach to this is really to look at what are your organization's strengths, and also what is your organization actually agreed to deliver on the most, and to who, like who's counting on you to deliver it. And I think those are places to start and say, where can we focus? What should we do if you're an organization approaching these different questions? I think I've spent a lot of time, and a lot of our leadership at Anthem has spent a lot of time thinking about this as well, particularly as of late. And even before now, to have sort of programs that have just recently won awards for looking at this. And so I think we've applied a good approach and lens. And as the health plan, you have a unique perspective and line of sight into certain things across the healthcare spectrum that sometimes not any one organization in it does, because you're a payer that's looking across vendors, providers, you have responsibilities to your membership and the patients there. And so there are a lot of stakeholders that speak to you, give you data, look to you. And so I think you have for us at Anthem, I think we take the responsibility very seriously of having that kind of line of sight and into some of the data. I think you touch providers, you touch, depending on your lines of business, different regulatory agencies where you can advocate for things like benefits and design in that way. And I think the health plan has a particular role maybe in looking at those things and trying to coordinate across the different entities in healthcare. So I think in particular, when I look at a health plan's role, that's what I see. I think each organization needs to ask those similar questions of themselves, though, and see where it is they should be focusing. I do co-chair a health equity council. We started that at Anthem a while back for the team, and the purpose was a cross-functional team to really look across all of the areas that either touch members, touch our providers, touch the regulators, to have representation there so that we could put that health equity lens on all of our programs, all of our interactions. And I'll just name sort of the 4 pillars we always use to guide that steering committee. And so one is data assessment, one is removing barriers, one is concordant interventions, and the 4th is policy integration. And we usually have this sort of like slide we always put up that has these pillars, and it's kind of like nice to look at and remind people of that graphic that we remind people of, but it's really like 4 pillars. And so everything we do, we sort of look to those pillars to say, are we actually upholding these, and what are we doing for those? So just briefly, for data assessment, obviously we get a lot of claims data in. There's encounter data, there's all sorts of data that the health plan does get in, and as the Medicaid team through the state. So looking at that, making sure we're having complete data sets, combing it through, pushing it to other partners. And I know we'll speak more about that later, but removing barriers. I think on the health plan side, it's a lot of like looking at how our contracts set up, how our provider relationships, is there access, literal access for members with transportation, with like providers in an area near you. Concordant interventions, in particular, I'll probably talk more about this later, but the doula program that we did win for actually really partnered with community and designed the intervention. So it really helped in ways that the community saw as helpful. And so when we look at concordance, we look at it in a number of different ways, but a lot of it on the community that's being served. And for the policy integration, particularly when I was with the Medicaid team, I think we did look at how do we speak to the state? How are we good partners with them and saying what's needed? What do we hear from our members, our providers, and advocate for those things to be incorporated in policies there, and internally, how are we reflecting that in our own team and playing that out for the good of everyone?
Thank you, Dr. Malloy. Kristen, would you like to weigh in?
Sure, thank you. Thank you also for having me here today. I'm really excited to be part of this panel and this discussion. So yeah, Sutter Health is a large integrated health system throughout Northern California, and we have a very diverse patient population. We have really extensive reach within many communities. We are a majority minority patient population. So I think we have a real opportunity and also obligation to make health equity part of what we do, integrated within every aspect of the care that we deliver. And our journey has been a long one. So over the past, I'd say 10 years or so, there have been a lot of efforts happening within our system, but in isolation and silos throughout different clinics and different practice settings among different leaders and provider groups. And I think as we've journeyed towards really becoming a truly integrated system, we've begun to really think about this from more of a coordinated strategic level. And that has led to the evolution of this process that has led to this institute, which was formally stood up in December, but actually has been the really culmination of many years of work that has been done. And I think one thing that we really found important and useful was really taking a step back and looking at our current state. So a few years ago, we put together a report with about 18 different quality metrics across our system, specifically to look at health equity from the lens of race, ethnicity, and also socioeconomics, some other different ways to look at health equity, and try to understand where our opportunities lied and where we were doing well, where we could amplify those efforts. And so that work was really helpful in helping us to understand some of the areas that we might focus on and target as we move forward in really working on a strategy around how to, as I said, integrate health equity within quality, within all the work that we do. And so we've established this institute very carefully in thinking about how can we do this in a way that will help us to really address these complex issues in a way that may provide the opportunity for development of feasible and impactful solutions that really have a chance at being helpful in taking these disparities and reducing those gaps for our patients, but also for our local communities, and even models that potentially could be useful beyond Sutter in, at the state, national level, issues that really are affecting our society today, that the pandemic really shed a bright light on, that have been with us for some time, but have now experienced, thankfully, renewed energy in thinking about how we can really move the needle forward and tackle these really complex issues. So one way we do that with our institute is we have an internal advisory committee that engages on a regular basis our leadership from all the different departments within our health system. For example, population health, digital health, quality leaders, our ops teams, our community health, community benefit teams, our external affairs teams. So we come together on a quarterly basis to really discuss these issues, present some of the work that's being done, and also are engaging them in the development of a strategic plan, which we are currently undergoing right now. And so that's one aspect of it. And another thing that we do within our institute or domains that we're trying to develop are really these three areas that we want to focus on to really achieve that goal of integrating health equity within our operations. So the first area is focusing on metrics and insights. So we really want to look at our data, understand what data is missing. How can we get that data into the electronic health record? How can we use that data to inform programmatic planning and identification of opportunities and those insights that are really important to then understanding where we need to put our resources. And the second area is solutions and advocacy. So once we have that data, once we understand what's happening, how can we develop solutions that really are going to be changing the current state and really achieving those goals and those outcomes for all of our patients. and then taking those solutions and using those to then advocate for change more broadly. And finally, education and training, thinking about how can we prepare our providers, our frontline staff to really effectively and compassionately care for our diverse patients, and also bring up the next generation of clinicians and researchers to do health equity work and understand health equity work. So that's the approach that we've taken, and we're early in our journey in terms of the strategic coordination. At the same time, we've done so much work over the years that we're really hoping that we can really use this as a catalyst to achieve that greater goal of making this just part of what we do.
Thank you. And Eve, about SCAN. Oh, you got muted again there.
There we go. Can you hear me? Yeah, so super honored to be part of this, and thanks to my team also at SCAN who helped me think through this, folks who've been working on health equity for a long time. So in addition to what Dr. Malloy and what Kristen are saying, we try to think of it in terms of firstly recognizing our role in creating the inequities that exist today. So healthcare is not blameless, right? We like to be seen as the good guys, but healthcare, particularly in the United States, we have been part of the problem, and until we recognize that, I don't think that we can be part of the solution. So, we often talk about treatment adherence and patient compliance, et cetera, but really putting ourselves in the shoes of the people we serve, putting them first instead of our systems and the outcomes that we've been told we're supposed to look for, I think is really key to what we need to do. So once we engage in that, I think we come across to our population as more authentic. And when we come across as more authentic, we build the trust that's needed in order to move forward. So I think that's number one, what I would say. Number two is we too focus on pillars. We happen to have selected pillars from Institute for Healthcare Improvement, their health equity mission. And a key pillar to that is institutionalized racism. So our workforce is this workforce. Our workforce is a workforce made up of people of color, and paying living wage, giving people opportunity for self-care, recognizing the inequities that exist in their own treatment, providing good healthcare coverage to them, good support to them, training not only how we're going to train our patients, but how they can maintain their own health in their job. I think about nurses and back injuries and all sorts of things like that. I think about the fact that Filipino nurses are the largest portion of the workforce that have been impacted by COVID, even, not proportional to their actual presence in that workforce. So I think there's that piece. So recognizing our role, recognizing who we are, and taking care of the people who enable us to do the work that we do. And then, recognizing the disparities that exist, the ones that we can do something about, because we can't fix everything. And for SCAN, we're an organization that primarily focuses on older adults. So for us, it's not only recognizing the inequities that exist today, but going upstream. An African-American 18-year-old male doesn't get to be an 89-year-old African-American male unless we do something about gun violence, unless we do something about poverty. So I think it's not just the population that we serve, but it's looking upstream and the root causes of what we do, in addition to everything else that folks have mentioned.
Thank you, and thank you for just naming healthcare's historical role in creating some of those inequities. I really appreciate that. So you all have mentioned, I've heard data come up a couple times, right, and how we understand inequities and how we might look for opportunities to address them. So let's talk a little bit further about that. So healthcare has long relied on data to focus our efforts on quality improvement and health transformation. How do we look at data differently in a post-COVID-19 world? And how should data regarding health equity or inequity be included in health system transformation? So let's start with Kristen this time.
Sure. No, thank you for that question. So this is something that I think is really an area of focus for us as we try to build a foundation of data assets and understanding our data to be able to inform our actions and drive the different types of solutions we hope to develop. And so I think the EHR really has unrealized potential in the way that it can help us to address and conquer some of these really complex challenges. So our efforts really began quite some time ago in 2010 when we had a system level effort to improve our capture of race, ethnicity, ancestry, and language data within our electronic health record. We had a self-report process. We tried really hard to make sure that we gave granular options, especially for ancestry, and really tried to make sure that data was high quality. And really that data has facilitated a lot of the work that we've been able to do so far, recognizing that race and ethnicity is really a proxy for many other structural racism and socioeconomic factors and societal factors. But really it is something that is important to consider because we don't have a better way at this point to measure some of those things for our patients. And so having that data has really been instrumental in the progress that we've made. However, we do recognize that we need to do better. We need to understand those root causes that Eve had mentioned. And social determinants of health data is a really key piece of that. So our system right now is undergoing a process. We've done several pilots so far to really take the recommendations of the Institute of Medicine, the now National Academies of Medicine, to really try to capture in a standardized way social determinants of health data within our electronic health record so that we can use that to inform our work, as I mentioned, in terms of finding those opportunities and then addressing those root causes and trying to understand how we can play a role in that. And recognizing that some of these factors are beyond our walls, but require partnership with our communities, partnerships with our public health system and others to really begin to make change. And so social determinants of health data will help us. I think there are other data that are missing. So SOGI data, sexual orientation, gender identity data, is another piece of data that we hope to make progress in terms of our electronic health record. So I think there's a lot of opportunity there to really think carefully about what kinds of data we have available, and to take the health record beyond the initial intent, which was to have a tool for a one-on-one clinical interaction between a physician or a nurse or a clinician and the patient, but now to really leverage that, to think about using that data at the population level for population health management, for programmatic development, and also for research, so public health research and medical research that can be done, observational studies. So there's a lot of potential there. I think I really do hope that beyond that, we can think about how to use that data and also partner with others to make that data even more actionable.
Thank you. Eve? I think you're on mute, Eve.
I guess I double myself. I don't know why I clicked and clicked. Super great points, Kristen. I agree. I think the balance between population level data versus individual level data that's going to be used from an analysis perspective versus data or information that is really about who I am as an individual and when I show up to my provider and how I want to engage my provider. So SOGI data is a perfect example. We deal with an older population. So there's this perception, and a lot of people in our organization, well, firstly, that maybe older people aren't gay, bisexual, transgender, which is wrong, or that they might be uncomfortable sharing. So I think whether it's race data, language data, SOGI data, we have to understand the comfort level. And so what we did is we did a survey of our population to say, what data elements are you willing to share with us and under what circumstances? And I think it was super helpful because it broke the myth that people aren't willing to share certain data elements, but it also helped us understand that people are willing to share certain things with their providers and certain things with their health plans. And the irony is the thing that they didn't want to share was actually their financial data, their income, more than their sexual orientation, more than their race, more than their religion. That's what they didn't want to share. And the thing that they were most concerned about is not whether or not we had the information, but how secure that information was when we had it, so that other people would not have access to it for something other than its intended purpose. So we thought that was super interesting. And now, because of that, we are embarking on collecting SOGI data through our health risk assessments and various other things. But different people in the organization, our sales team doesn't feel so comfortable about collecting SOGI data, but the people who do our health risk assessments do. I think the other thing about data is, we've collected and used a lot of data mandated by whatever quality measures we're incentivized by or whatever reporting standards are required. And it might be the wrong data, right? It might not be the data that are most meaningful. So I do think that social needs data, or social determinants of health, what most people call it, is important data for us. For older adults, functional status, how they perform with their activities of daily living is hugely important to their overall outcomes, but it's not necessarily a set of mandated data. There's no CMS 5-star metric, that says how many ADL deficits does your population have. So I think it's also important for us to understand what data we're collecting, and is there a better way to get at data that matters. And in our mind, that's really the way we get to that is through human-centered design and co-design with the folks that we're engaging with to say, what are the outcomes that matter to you? Therefore, we can figure out what the data are that are important to you, and to recognize that, population level, no population, no culture is a monolith, but we need data in order to drive resources to the right place. And then we need real information about individuals to solve individuals' problems and meet their needs.
Thank you so much. Dr. Malloy?
Well, I'm learning so much by listening to my co-panelists. I think those are such great answers. I mean, a lot of agreement with what was said. And I think it's actually somewhat comforting to know that we have the same challenges, which is balancing between that, 30,000 foot view and then being able to be on the ground and actually even, go down a rabbit hole with something that really needs that extra high touch and attention once identified. And so it is sort of which data points, which metrics help you identify the place where you should go deeper, and then can you even get more information there once you need to. So I think I certainly agree with that sort of balance. I also agree with that, two major things I think are important with that, which is, Kristen, what I heard you bringing up really was capacity building for that, in your internal staff, in the understanding. I also would say, when I look across the different lines of business, advocating with regulatory agencies, people who set quality standards to understand what is important and what is part of that quality of life, and things that you were referring to, Eve. I think to build in incentives for actually collecting that data, for people paying attention to that, for fostering effective conversations around interventions and policies for those things, because that's what has been identified of what matters to the patients, to the members, to the providers caring for them, right? To the communities, the caregivers, everyone around. If that's what they said is important, we should certainly weight that in our decisions on what are we tracking and what's important. So there's that sort of capacity building all around in the system. And I think different healthcare entities can help with different areas of that. And then I think it is engaging your internal staff to be in on this constant conversation, right? I think that why we established a Health Equity Council was so that was a thing on the calendar that said we're all coming together to discuss the following, and here's the agenda. And a lot of what we did was go across different functional areas to say, for your existing programs, that we often use the term health equity lens. So for your existing programs, the things we're already doing, the things even say the state says we should be doing, or Medicare says we're doing, can we look at that through a health equity lens? So maybe the average is okay, maybe we're performing overall fine, but can we parse it out and say who's not doing okay, even though from the 30,000 foot view, it looks like it's okay, right? And where should we be doing that? Even with programs that you would think would be targeting or helping, like even when you're bringing up the LGBTQ community, I was thinking about even other things. If we looked at like housing support that we were doing or food insecurity, and like they're not engaging, and maybe like either maybe the younger population in that subpopulation or the older ones. And why are we not where they are? Are they not hearing the messages? Do they not feel safe coming in and saying that information about themselves and getting connected to other resources? And I agree with you. Sometimes they don't want to tell the health plan that. So the key there was really community partnership to say, who can we empower to have this information and act on this information, even if we're like behind the scenes, paying for this and setting this up. Like, what is sort of seamless and comfortable and engaging to the member up front? And like, how do we just facilitate that? And then are they comfortable giving them data that they're then going to enact on? And like, maybe we don't need to see all of it, or maybe we just need to know what data they're using and referring into programs that we're paying for. But it's kind of that partnership to get that kind of access and that kind of data being used meaningfully, collected and used meaningfully. So I think those kinds of things, just tying in a lot of what you guys already said, are important things to consider.
Thank you all. So let's think about a kind of a very concrete example of health equity in action. So maybe we can quickly hear from you all around what, if any, role your organization has played in ensuring the equitable distribution of the COVID vaccination, right, to populations most in need. And Eve, let's start with you on this one.
There we go. I have a double click thing. So just to the previous point that Kristen and Dr. Malloy were making is, I think democratizing the data about inequities is also super important. So being able to collect all the information about race, ethnicity, and language, SOGI, et cetera, and then putting it at a population level and dashboards for people to see the inequities. And that's been super powerful for us. And honestly, it took a long time. Like, it took a long time for us first to like agree what are the race categories we're using. Do we use the Medicare ones? Do we use the Medi-Cal ones? Do we use some other code standard, et cetera? But where we are now, and it comes to the COVID point, is we now have an amazing dashboard of who's been vaccinated, who hasn't been vaccinated, by race, by gender, by language spoken, by whether we have an email address for them or not, because that's a proxy for us for digital access, which is a big issue for our population. By homebound status, because we have folks that meet criteria for being homebound. How do we ensure that population first gets their vaccine? So we have an amazing dashboard that then allows us to see where we are with the different populations, to know, okay, let's focus here. We think there's going to be an inequity here, so we start a program, but now we know, because we could track it along on the dashboard, whether there is an inequity there or not. But like, interestingly, this dashboard was telling us initially that our Asian population was our highly vaccinated population. Okay, well, that still doesn't mean now don't focus on the Asian population. So we also have to, when we democratize the data, we have to make sure that we understand what it can tell us and what it can't. But for us, homebound is the population we started our focus on. We have about 6,000 folks who are homebound in our population. It's super hard for them to do a drive-through at Dodger Stadium to get their vaccine. So, working with an organization that has a paramedic workforce to get the vaccine administered to folks in the home. The dashboard, as I said, in addition to ways that we can, figuring out which populations we need to focus on, although the data are lagged because we get it from the federal government. So what we've done then instead is we've done a lot of education and outbound call campaigns. So on the education side, we have a platform. We have to go old school. Our folks are, people of color have access to digital, have barriers to accessing digital technology. Older folks have barriers to accessing digital technology. So older people of color are doubly burdened by this, but all of the vaccines in our state, you had to go online to make an appointment initially. So how do we do that? Well, we went old school. We have a telephone town hall kind of thing where folks can call in, and we broadcast the phone number that you call for your county, as well as we mine our member services data for people who are having issues. And then we're doing outbound calls to those folks, both staff whose job it is, they're clinicians and they're doing this, as well as staff throughout our company have volunteered to help our older adults make that appointment if it's really hard for them to make that appointment. And then we have had targeted outreach specifically to our Spanish-speaking population, our African-American population, and our Asian population, particularly those who don't have English as their first language, where outreach workers are calling them and facilitating the actual appointment. And then lastly, we're working in partnership with a lot of the providers of the vaccine to either hold slots for our older adults that have functional deficits so that we can provide them the transportation, provide them a home care worker that will go with them for that vaccine appointment. Because for an older adult to stand in a line waiting to get their vaccine appointment 6 feet from somebody else without anybody helping them, with no bathrooms available, imagine what incontinence does for folks who have to wait in those long lines at Dodger Stadium. It's super hard. So we've been facilitating that with the support to actually go get the vaccine when we can't bring the vaccine to them. I'm sure there are many more, but I'll turn it over to the others.
Thank you so much. Let's try to hear quickly from Dr. Malloy and then Kristen, and then we'll jump to a question or two from our chat. Thank you.
Great. Yeah, I think, we're approaching COVID in general, it started, pretty early. Like, so even before the vaccine, when we started with testing, and it really had partnerships with like FQHCs in South LA, and our community-based organizations for promotion. So we piggybacked on even food drives and things that they gave in order to promote and say there's testing available. Here are your providers in the community that you already trust that you can now also go to for this service, and sort of stood in the background. I mean, we might have had like a banner up that said Anthem is sponsoring this when they went to the testing site, but it was really about having them interface with who they already trusted in the community to have those things done. And then with the vaccines, we actually started with flu, because the idea was to lower the respiratory burden in general that already disproportionately affects different communities of color and low wage earner communities as well, to get sort of that ball rolling and engagement with vaccines, with something that we knew we didn't certainly want people to have a double hit and have COVID and have the flu, et cetera, and the different burdens that puts on families. So we had pop-up clinics, and what we did is we looked at geography and made sure that we put those different access points that we added to the community in communities that did need it, right? Did have lower access points and had historically, based on data that we looked at, had less engagement with the flu shot in the past, right? So, but again, we partnered with the community-based organizations to really drive the messaging, be the actual site that something did happen at. And so I think we sort of greased the wheels for some of that engagement, and in general, and some of the leaders and partners that were already identified in areas that we wanted to make sure that we targeted, and then also heard from the community on other things like it's really important to get kids back to school for working moms who've been taken out of our work system, and that's disproportionately affected, low wage earners, essential workers, and also women of color in particular. And so, as an equity assistance there as well, we tried to make sure, we partnered with Los Angeles Unified School District and made sure we're getting teachers and staff vaccinated. So we set up a mass vaccination site. And again, we did this in Inglewood, and we tried to make sure that there were, really big access points right in people's neighborhood where we could actually really move the needle on things that were important to everyone, right? But also definitely helped with equity issues that we knew were disproportionately affecting others. So finding those sort of sweet spots, definitely with in partnership with community-based organizations and hearing what was important to them and how would this work to be implemented. And using our data to also pin that down. And then, using our ability as healthmen to work with contracting and bringing providers out and getting things set up and having even volunteers from our larger organization go. We had a lot of volunteer hours from Anthem for these sites, all of those sort of things. But I think our role was really coordinating a lot of that. And we just did that because we knew how important it was. We also knew how much it could move the bar on some of these equity pieces. And so I think, that kind of a role, we thought was important and a unique one we could play to coordinate across the healthcare spectrum. And those are really the approaches that we use, particularly with COVID.
Thank you. Kristen?
Yeah, so we have a similar experience to both Eva and Dr. Malloy. We initially began with place-based interventions, leveraging our existing community partnerships, community health, community benefit teams leadership really tried to get in there into the communities that were emerging as hardest hit and tried to partner with those communities and offer vaccination to anyone, not just folks that had traditionally been our patients or had our MRN, but kind of get people what they need at the places where they need it based on what they were learning from conversations within the community. And in parallel to that, our institute stood up a subcommittee under our vaccine task force to specifically look at health equity for vaccine distribution. And it took some time to get our data together, working with our pop health leadership, our pop health data teams to put together a Tableau dashboard to really start to understand how to look at that data from the perspective of the disparities that we were seeing and things like race, ethnicity, but also technology use, using proxies like emails or My Health Online, which is a patient portal access to understand where those gaps were. And so we were able to fairly quickly stand up a dashboard that also had a geospatial component. So we could start to really help to use data to guide the place-based interventions, which we are currently doing now, looking at how we can look at the Healthy Places Index and the zip codes kind of hardest hit against our unvaccinated patients and start to really hone in on the places where we really need to be and support. So that's been our journey. So we're meeting. We meet regularly each week, and we produce reports each week to look at how we're doing. And another, I think, really key feature to that is in setting our targets. We had some early on conversations about really the difference between equality and equity, and how we think about what our goals should be in terms of vaccinating our patients. Not to say that we would ever deny any kind of treatment to anybody, but in thinking about if we reach a goal for one group, maybe we need to think about a differential allocation of resources towards another group to get them to their goal, because the goals may not be the same. And that is the difference with equity and equality, is that if we have a goal, an equality goal for everyone, which is to achieve herd immunity, thinking about then what above and beyond that needs to be taken into account when you look at the disproportionate burden of COVID among our patients and who those patients are that are really highest risk for being infected and also being hospitalized and having death as a result. So that's our approach, is really trying to have an equity lens in terms of our targets, in terms of our data, and then how we're now at the point where we can really look at that data and start to operationalize it to create phone lists of those patients that we know really are not achieving their goals, and trying to understand. So there are some challenges with that, of those, we have our data, but not being able to see who has been externally vaccinated has been a challenge for us to understand what that gap is. And are we, duplicating efforts and calling some patients when maybe they've been vaccinated elsewhere? Or there are still issues of hesitancy among some patients in a variety of different socioeconomic, subgroups of patients. And so thinking about how do we also think about that when we make these phone calls, and maybe provide some education or at least understand what those challenges are. So it's a work in progress, as I'm sure my colleagues have also experienced, but it is top of mind and a priority for us to really make sure that we try to do our part to make it as equitable of a distribution as possible.
Thank you so much, all of you, for sharing your wisdom and experience with us. We don't have much time left, maybe 5 to 6 minutes, because I know folks have to transition to the next session. But we have 3 questions in the chat, and I'm going to try to combine 2 into one and see if we can at least get that one answered. And that's really a question that comes from Elizabeth and Crystal. Elizabeth's question is around asking if any of you have used an intersectional approach to how you're moving forward with either your programs or like data collection. Crystal's is around any new innovations that lead to better data collection and in turn better health outcomes. And in some ways, I'm going to kind of say, an intersectional approach, right, to how we see multiple identities impacting health and health equity could be one of those innovations. So can any of you speak or want to speak to any kind of intersectional approach in your work or other innovations? And I'll open it up to anyone who wants to jump. Eve, looks like you want to.
Yeah, so I mean, one of the things we wanted to learn was if our providers, so we're a health plan, do our providers collect better data than we do? So we partnered with one of our providers, Memorial Healthcare System, which is a large system in our community, and we shared data on our shared members, what they had, what we had, to see where there were differences. And it turns out that we were kind of on the same page. There were slight differences, but the folks who didn't want to respond didn't respond to either of us, So it was sort of interesting in that way. I don't know that, now we're working on SOGI data because we're both interested in that. But that's just one example.
I would say that we looked at whether some providers got information too, but where we actually found supplementation for our data and data we maybe would never have access to in the ways or weren't asking the questions was with our community-based organizations. So for example, I think the reason why our doula program did really well was because we partnered with an organization that asked questions of its, who it was serving, completely different from ours, right? Because they had a very focused niche. And we were looking at the maternal birth equity issue. They asked a lot more deeper questions around that. And we ended up having our referrals into our doula program largely come from the community-based organization because they were able to identify with much more specificity and to have that initial engagement and trust and warm handoff and facilitate that kind of action. So I think, they asked a lot of things about people's home environment and what their, and their relationship status and do they feel safe at home and those different things that we would love for our high risk OB case management team to have had, but we didn't have them to that degree. So we weren't able to necessarily, but pairing it with our data on, who had premature births in the past, part of their claims data or complications in their inpatient stay or something, and pairing it with them being able to identify, who might, agree to help now, who's engaged with them really, really helped us target and really get women in the program that really needed the help and really were who we were looking for, but I don't know that we would have gotten that sort of robust response and that sort of level of engagement either without pairing those two together.
Yeah, I would just say, I think partnerships are really important for this. There's the aspect of the data collection, but there's also the aspect of intervention and thinking about how we can engage multiple different stakeholders, whether it be in the community or different academic institutions or payers, or however we can do that to really put together a comprehensive view of the issues and of the contributors and underlying causes of the disparities that we're seeing. But in terms of actual data collection, thinking about health information exchanges and community health records and how those types of tools can really help us to manage our shared patients, which we know within a region, go to our facilities, to FQHCs, to, the other institutions, and trying to understand what the possibilities are there. Of course, keeping in mind at the forefront, privacy and security and all those things, but thinking about how we can use that information and the continuum of care to really inform what we are also doing to help folks get back to their medical home, for example, and much of what Dr. Malloy was saying of kind of getting the bigger picture of how all these pieces of the health system fit together to really create that continuum of care that's needed. And in terms of innovation and just in general, I would say if this is a question from the perspective of a health system trying to collect this data, I think being intentional and thoughtful about how we design these standard work around the data collection, how we bring people along, our providers, our staff, our patients. I know Eve mentioned asking patients how they felt about being asked these questions. We are doing the same in these pilots for social determinants of health, trying it in different settings. So ambulatory settings, inpatient settings, learning from each small pilot to help to inform the bigger strategy and the bigger protocol that we want to implement, working with the leaders in our pop health team to do that as well, to understand when we identify a need, how we can connect to a resource rather than just identifying a need and then not being able to offer any kind of a resource for that individual. So I think it just takes really that work. It's a work.
Okay, I think we are, there's a delay, but thank you all so much. I know we are out of time, and there's a little chat that we're wrapping up the sessions. If anyone is still out there, I just want to acknowledge there was one more comment in the chat that I thought was very important. I wanted to just uplift, which is thinking around what is healthcare's role in resourcing culturally specific or ethnic community-based organizations who are doing some amazing work in our community, especially delivering non-clinical based care. And so, we couldn't answer it, but I just want to throw that out because I think it's a very important point to lift up for healthcare to think around. Again, what is our role in putting resources to those communities that are really on the front line doing some of that work that healthcare can't do? So thank you all, appreciate it. Again, Eve, Dr. Malloy, Kristen, really appreciate you sharing your wisdom and experience. And I hope you all have a good day and enjoy the conference.
Thank you.
Thank you so much.